Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, I'm Rajiv Agarwal, Professor Emeritus of Medicine at Indiana University School of Medicine in Indianapolis, United States. Welcome to this discussion titled CKD and the Heart, an expert digest from WCN 2026. Joining me today are Dr. Catherine Tuttle, Professor, Division of Nephrology and Kidney Research Institute, University of Washington, and Executive Director, Providence Medical Research Center, Providence Inland Northwest Health in Spokane, Washington, United States. And joining me today is Dr. Naoki Sato, Professor and Director of Cardiovascular Medicine and Vice President of the Kawaguchi Cardiovascular and Respiratory Hospital in Kawaguchi, Japan. Welcome.
Thank you for having me.
One of the four key themes at this year's WCN Congress is the interconnected kidney. Today, we are going to take a multidisciplinary approach and dive deep into the detection, treatment, and management of CKD in the wider context of CKM health, discuss guideline recommendations for screening CKD using albuminuria, and share our expert perspectives in incorporating current evidence-based strategies supporting combination therapy for cardio-kidney protection. CKM syndrome is characterized by multidirectional pathophysiological interactions among excess visceral fat, metabolic dysfunction, chronic kidney disease, and cardiovascular disease that create self-perpetuating cycles of multi-organ damage. These mechanisms can be broadly classified as hemodynamic, metabolic, inflammatory, and fibrotic. CKD serves as a major risk amplifier through systemic inflammation, vascular calcification, anemia, and bone mineral disorders, with albuminuria and reduced GFR independently associated with progressive increases in atherosclerotic events, heart failure, and cardiovascular death. Albuminuria screening is particularly valuable as it identifies early kidney disease and global vascular dysfunction before significant eGFR decline occurs. The emergence of multiple interventions that can change the trajectory of disease in these patients through early detection makes it particularly important for clinicians to be aware of them. Let's first talk briefly about important biomarkers guiding CKD-CKM risk assessment and treatment decision-making. Kathy, to what extent does albuminuria act as a primary driver of CV risk and CKD progression? How should contemporary evidence-based UACR thresholds and serial reductions be used to guide reno and cardioprotective therapies?
Well, we know that albuminuria really is a major risk amplifier, both for loss of kidney function and kidney failure, as well as the competing risks of major cardiovascular events, both atherosclerotic events and heart failure events, as well as death. It is probably a marker of generalized endothelial dysfunction and organ damage, which is why it is such a powerful indicator. And in fact, the new PREVENT equation for evaluating total cardiovascular risk incorporates EGFR and, when available, UACR. UACR actually adds to the risk, but because screening has been so low, it's, quote, not required for the calculator. But it's probably one of the most important indicators beyond conventional risk factors of the risks of these major outcomes. And what's really important is it's modifiable. And it's modifiable by contemporary treatments and can be used to monitor response to therapy so that we can really tailor intensification of risk reduction to the level of risk.
I think you make a very important point that it's modifiable. And if we detect it before the decline of kidney function, we have an opportunity to act where there is smoke instead of letting it become a fire.
Exactly. And remember that preserving kidney function, of course, prevents kidney failure, but it also prevents the major cardiovascular events, because loss of kidney function, as you described, leads to a number of complications that further amplify cardiovascular risk beyond conventional risk factors.
Naoki, tell us about the strategies to differentiate between the initial dips in EGFR versus acute kidney injury.
Yeah, that's a very important question, and sometimes it is difficult. But I emphasize 3 points. One is the patient has symptom or not, and after initiation of the new drug. So we have to check the volume status and the cardiac function or blood pressure, especially hypertension, etc. And then second, and regarding to KDIGO statement, 30% decline is acceptable. But more than that, and we have to check the patient has symptom or not, or check the blood pressure and maybe BUN creatinine ratio and the volume status I can evaluate in a simple way. So, and then it depends on drug. If you give SGLT2 inhibitor, it's usually in the 2 weeks and 4 weeks the initial drop occur. But if you give the non-steroidal aminophenoline, it takes 3 months and gradually decrease. So that's why we have to take a look in the EGFR decline and depend on drug. Yeah. Do you agree?
Yes, and I think taking from the cues that you said, look at the volume status, look at the blood pressure, and sometimes people have this knee-jerk reflexes that I started an SGLT2 inhibitor, I must remove it. What I typically do is that lighten up on the diuretics or lighten up on the other antihypertensive drugs and let the GDMTs still be there.
Right.
So, you just don't reflexively remove what you intended to. So let's move on to the latest guideline updates and treatments for heart and kidney protection. In September 2001, we saw publication of 2 landmark trials involving angiotensin receptor blockers, RENAL and IDNT. For the next approximately 2 decades, many trials in kidney disease patients failed to reach the primary endpoint. However, in 2019, the tides turned. The CREDENCE trial was announced, which received regulatory and guideline approval for SGLT2 inhibitors in people with type 2 diabetes. The following year, in 2020, saw the publication of the FIDELIO trial. In this trial, finerenone in patients with later stages of diabetic kidney disease, and in subsequent year with the publication of the FIGARO trial in T2D, CKD in people with earlier stages of DKD, demonstrated both kidney and cardiovascular protection. In 2024, there was the publication of the FLOW trial that demonstrated cardiorenal protection with once-weekly injectable semaglutide in patients with type 2 diabetes and chronic kidney disease. In 5 years, we went from just 1 to 4 pillars. This leads to an interesting conundrum with access to therapies, including combinations, timing, sequencing. We began grappling with the problem of whose drug is it anyway? So, Kathy, what are the roles and responsibilities amongst clinicians for implementing and sustaining GDMT and CKM? Whose business is it?
Well, to be honest with you, it's everybody's job. And I think we need to de-silo ourselves and really work toward that aspirational goal of team care. The most important thing is to get people on these highly effective therapies that save kidneys, hearts, and lives. And it's not about a competition between specialties, it's about a collaboration. And admittedly, this is difficult because we historically have worked in a more siloed fashion, but we really need to move forward to treat the totality of risks in a more holistic fashion. And so, in my view, the goal should be to get people on therapies, as you mentioned, to not delay, to get them on quickly, because time is nephrons and time is heart. And so we shouldn't be waiting for the next person to adjust a dose or initiate a therapy. So what I would like to say, it's everybody's job. When you see the patient, if they need to have a drug initiated, please start it. And then if I see the patient next and a dose adjustment needs to be made, then that's my job. And we should be working in a collaborative fashion. I realize that that's an aspirational goal. It's difficult depending on settings and circumstances. But I believe that individuals working within those settings, if they set that goal, can, within their own context, think about how we do this better, because we've waited way too long, especially in CKD, to get people on the full portfolio of therapies, and many patients pay a big price for those delays.
So, Kathy, as you were talking, my head was ticking, and I was thinking that, we do surveillance in the United States, and in airports they say, see something, say something.
Yes,
right?
exactly.
So if you see something like albuminuria, say something, which means that you need to be treated and
Right.
treated, do something. We
That's
should
right.
change it to see something, do something.
That's exactly right.
And albuminuria, as you said, is modifiable. And if we see that there is an improvement, we might be able to tell the patient, look, I'm treating you with these therapies. You were at a higher risk before. We have improved your risk. Please keep taking it. And we shouldn't stop till we get there.
Exactly. And every one of the therapies that you discussed reduces albuminuria. And while we are awaiting combination therapy studies, there are a few, we'll talk about confidence, but all of the available evidence from confidence, as well as in analyses of the trials where people may have inadvertently also used another agent, point to combination therapy being additive. And so if a person is on one or two therapies, they still have residual albuminuria, we should be adding the next medicine and then titrating it to the optimal dose so that we get the maximal albuminuria reduction, because that will translate into marked reductions in risk.
Thank you. So, Naoki, we have been learning from heart failure world, and what are the roles and responsibilities among clinicians for implementing and sustaining GDMT in CKM? In your view, what are the guideline updates for GDMT in 2026?
Yeah, I think it is important to guideline the statement in the 5. And the first one in 2023, HA and talking about and CKM. And I think it based on the concept of the metabolic domino and for the cardiovascular disease. So if take a look at the mineralocorticoid receptor activation in the adipose tissue stimulate mineralocorticoid receptor by a leptin pathway. I think it is, most people don't know that way. So it's a systemic in the some kind of neurohumoral activation. It's related to mineralocorticoid receptor activation. So that's why CKM, its concept, is really important. And based on that concept and the HA statement and the CKD and diabetes patient and the 2026, and that emphasize maybe 2 paradigm shift. Is we got some new drug, SL2 inhibitor and GLP-1 and RA, and also and non-steroidal MRA. And then, and the second paradigm shift, and give the combination therapy. It usually takes one drug, give it one drug, and take a look at the 1 year, 2 year, and then if it doesn't work, it may be considered another one. And already you show the combination trials, so maybe give it simultaneously, and the effect is more. Additional effect is really tremendous. So I think it is really important. So those guidelines suggest and the combination therapy is really important. And also published Japanese Heart Failure Society and Japanese Psychiatric Society Heart Failure Guideline recommended the quinolone. This is the first time in over the world, but the evidence is really important. So we encourage to try to a combination and the non-steroidal MRA and other drug. And we have to learn the strong HF and the standard therapy and give the simultaneously. And based on the protocol of strong HF and half dose of the GDMT, and 2 weeks later, nothing happens, so give the full dose. I think it's really important to try to optimize dose of GDMT. Yeah.
So a couple of things I learned from your exposition of this issue is that it has a strong pathophysiological basis, and the visceral adiposity that you indicate is interventionable by multiple pathways, SGLT2 inhibitors, GLP-1 RAs, and even through the leptin pathway, the MR activation. So visceral adiposity is really important. And second, you told us that we have a pathway in cardiology where we start simultaneous therapies in half dose, wait 2 weeks. If nothing happens, you go to the full dose. That's the strong HF trial. It's a good segue to take us to the next discussion is to look at the rationale for dual pathway blockade and synergistic protection with combination therapy. And let's look at this rationale. Since CKD is driven by multiple pathways, hemodynamic, metabolic, and inflammatory, no single drug can eliminate residual risk. And now we have multiple therapies. We used to call them pillars, but we can build the pillar any which way we want to. We have become more flexible, but they include RASI, SGLT2 inhibitors, finerenone, and GLP-1 RAs that provide additive cardiorenal protection. And evidence shows that combining these therapies reduces risk by anywhere between 15 to 35% per class, with triple therapy potentially extending CKD-free survival by over 5 years. These are modeling studies, and we have looked at multiple therapies, but we find that if we do all of what we need to do, we can extend the lives of our patients by approximately 5 years. Furthermore, combinations like SGLT2 inhibitors with finerenone can actually mitigate complications like hyperkalemia. So we are moving towards a simultaneous multi-pillar strategies to maximize lifetime benefits beyond what any maximized monotherapy could achieve. So Kathy, how should clinicians interpret the confidence trials finding on combined finerenone and SGLT2 inhibitor inhibition for CKM care?
Well, I think there are two really key messages. First off, highly effective and additive benefits on reducing albuminuria by combining empagliflozin with finerenone. And that was a prospective study, as opposed to in the prior trials, we had to look retrospectively at whether or not people, like I said, inadvertently got one of the other classes along with whatever the randomized treatment was. So that's very important. It validates that those observations were pointing us in the right direction. The other major concern is safety. And what we clearly saw out of the confidence trial is it was safe. We did not see excessive eGFR dips, hypotension, hyperkalemia. And that really provides confidence that we can rapidly implement combination therapy. And I think that's really important. And especially because while we're actively trying to reduce kidney and cardiovascular risk, we always have to be mindful of safety. And I think, this trial was one that really proved efficacy and was very reassuring that we could do this simultaneously and not put people in harm's way by doing so.
Yes, and we have analyzed this further with deeper dives into it. And two interesting things come out is one is on the EGFR. So, that's the dip that people are concerned about, and the reflex is that, oh, the GFR dipped and I'm going to remove the therapy. The second is that the GFR is 35. Do I really need to start simultaneous therapy? And if I start it, maybe I'll put people in harm's way. So when we look at the data, we find that the people who have the dips are the ones who have the higher GFRs. And when you have a lower GFR, you really don't dip. So it's a smart drug. You can't really dip so much. The second issue is sexual dimorphism. What we find is that women have a greater response, about 20% greater reduction in albuminuria compared to men in the confidence trial. When we look across the Fidelity, Feinheart, all those programs, we find that GTMTs are not so much implemented in women as much. And women lose the advantage of having less cardiovascular disease once they are inflicted with diabetes. So that advantage goes away. On the other hand, we're finding that albuminuria reduction is actually more if they are given these therapies. So we have to be mindful of providing access to people who are at higher risk instead of worrying about, if I start this, we might put people in harm's way. So moving on to Naoki, what do clinical trials and mechanistic data show about the incremental benefit of combining SGLT2 inhibitors with GLP-1 and RAS inhibitors for cardiokidney outcomes?
From the viewpoint of cardiologist, I already told you the strong HF and the combination give the and simultaneously and improved outcome. And before that, I have no experience in the simultaneous and the combination implementation with the JDMT. So, but actually we conducted a Japanese and the strong HF trial. It's really effect. And the NT-proBNP dramatically decrease. And the combination therapy is really important because each drug has different mechanism to improve the outcome. So that way we need a combination, and we have learned a lot of things in the combination trial and give the drug. And from the viewpoint and the glomerular pressure, it's a different mechanism, right? SGLT2 it decreases glomerular pressure by SGLT2 and prevention and SGLT2 activation. So, and also the angiotensin system in the by angiotensin 2 and increase glomerular pressure and prevent by MRA.
Yes.
Yeah.
So 2 points that you make is simultaneous initiation and low dose initiation. I think that in general, physicians have had hesitancy in starting two drugs because we were taught in medical school polypharmacy is not good. Start one at a time. Look at the side effects. You start two. How will you know what side effects the person is having? But what we show from clinical trials is time is tissue. When you start two and you can get the benefit in 2 weeks, what takes 180 days, it's obvious for the patient perspective that you're going to benefit. You raise another important issue about intraglomerular pressure. And what we find is that the initial dip in GFR of 30% or whatever, we used a numeric scale, just a continuous measure, has really no bearing on the subsequent decline in UACR. So whether you drop or you don't drop, it doesn't really matter. What matters is the UACR reduction because that is protective. And numerous other studies have shown that if your GFR drops or increases, it really doesn't have much of a bearing on kidney or cardiovascular outcomes. So moving on to both of you, how should clinicians be managing side effects such as hyperkalemia in this? Okay, first tell me, because cardiologists have dealt with this for a long time, hyperkalemia. What's your approach, Wayne?
Yeah, I think it is one of the key issue is we have to tell the patient and the potassium intake. And sometimes the people and I eat banana every day,
Yeah.
something like this.
Yes.
And when you start an MRA and maybe have to tell and reduced the intake of potassium, I think it's really important. And also in Japan, summer is very hot, so all the people do not drink water, so avoid dehydration. I think this is very important. And based on that, and give the MRA or other renin-angiotensin inhibitor, and take a look at the 2 weeks and 4 weeks later, and check the potassium. And if more than 5.5 is maybe we have to take and watch out. It's really be careful and continue the same dose, but more than 6, and maybe we should try to discontinue.
Yes. Kathy, any addition to this?
Well, one thing that I'd like to bring up is that SGLT2 inhibitors actually reduce risk of hyperkalemia. In meta-analyses across different kinds of trials, it's been very consistent, about 25% reduction in risk of hyperkalemia. So one of the reasons to have an SGLT2 inhibitor on board, either with simultaneous initiation or prior initiation, is it increases the safety of adding drugs with a side effect that causes hyperkalemia. So I think that combination is particularly attractive from the standpoint of reducing hyperkalemia risk as well.
So both improving the efficacy and the safety.
Exactly.
Right. And I think that we have to shy away from removing these cardio and kidney protective therapies when potassium is, say, 5.1 or 5.2. People just stop it. And many times they stop it and never restart it because they label them as allergic. What we are doing is putting people in harm's way for kidney and cardiovascular outcomes in future if we do this, right? So give us an update on the key trials coming out in WCN 2026 and which data sets have impressed you the most.
Well, Rajiv, you've already brought up some additional analyses from the confidence trial. And I think they're particularly interesting and reassuring that, irrespective of CKD severity, we see the similar benefits. Again, for nephrologists, that's important because we have this risk treatment paradox where when we look at real world data, people at higher risk, that is with lower GFR or higher albuminuria, are actually less likely to receive GDMT. These are data that reassure us that those advanced patients actually have the most to gain. And then another thing that you brought up is now that we're focusing more on differences between men and women, this is really important. And women have been understudied and undertreated. I think the finding that finerenone is particularly effective in women is very impactful. It should be a message to clinicians that all your patients need treatment, including women, and this is a particularly effective therapy in women. And then we're also seeing a lot of new data on mechanisms that I think are really helpful as clinicians to allow us to understand how these drugs work. You mentioned the hemodynamic effects of SGLT2 and that other classes have different effects. There's some data being presented from the REMODEL trial, which is the mechanistic trial of semaglutide in CKD with type 2 that helps us understand the underlying mechanisms in flow. And basically we see at the tissue level, this was a biopsy study before and after a year of randomized treatment, a marked reduction in kidney fat, visceral fat again being a target, and then correspondingly reduction in the transcription of many inflammatory and profibrotic pathways. So it also, from a scientific standpoint, reassures us that what we've seen in models translates to humans, and that helps us understand then how we can apply these therapies in a complementary manner. So I'll stop and see what you think.
Yeah, I take a look at the program. So, and I agree. I want to know the mechanism
Yes.
of some drug. And already you mentioned in the remodel trial, it's really interesting and try to find out the mechanism why semaglutide improved that outcome. So maybe in the tissue effect or other genetically concept. And also, I'm interested in the fecal DKD trial already published, but activation of mineralocorticoid receptor is closely related neuropeptide Y, and which affect vascular resistance. So I think the sub-analysis I think it is really important.
So I think that this is a fascinating discussion. One thing that I believe that should be looked into more carefully is the phenotype of resistant hypertension. We haven't looked at it very much. There was just a big review article by Dr. Zizi and JAMA about a week ago that talks about resistant hypertension. And when we look at this phenotype, and it's so simple, it tells us that these people are at high risk and that MR activation is in the causal pathway of that, and volume retention is in the causal pathway. And perhaps that is something which is just sitting in front of our eyes and we are missing it. So that's something to look into perhaps in the future. But let's look at the key takeaways, which are to screen patients with diabetes, hypertension, atherosclerotic cardiovascular disease, and the elderly at least annually to detect the presence of kidney disease, particularly with UACR or albuminuria, so that they can receive the benefits of modern therapies. The modern approach layered on lifestyle modification addresses hemodynamics, glycemia, inflammation, and fibrosis, and they can have a large impact on the lifetime benefit accrued by people living with diabetes, CKD, and heart failure. By implementing these simple yet effective interventions, we can provide a service to the people with CKM who seek our care. Kathy and Naoki, thank you for this great discussion.
Thank you.
Thank you.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.